Okay, welcome everyone. I'm Mike Udell. I'm the Vice Dean and a professor here at the College of Health Solutions at Arizona State University. I'd like to thank you for joining our Health Talks webinar today, brought to you by the College of Health Solutions at Arizona State. The College of Health Solutions addresses the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These Health Talks are one way that we serve the community with timely and relevant health information that also provides continuing education credit at no cost. And now for a few quick housekeeping items. First, this session is being recorded and it will be posted to our website at asuhealthtalks.com. And after each of our panelists present today, we'll moderate a Q&A session, and please submit your questions using the Q&A feature in the Zoom webinar. Finally, you will receive a brief survey asking for your input about today's webinar. If you're requesting continuing education credits, this must be completed in order to receive credit. If you did not apply for CEUs, we would still appreciate your feedback to improve our series. So today's topic is mandates. Why are they a healthcare issue? Joining me today are James Dupay. James is a clinical assistant professor in history at Arizona State and is program lead for the North American track for the online Masters in History. James earned his Master's in History at Eastern Washington University and a PhD right here at ASU. And his research is focused on the history of religion and capitalism in the 19th century United States and the commodification of wellness. James will be followed today by Dr. Emer Lucy. Emer is a historian of medicine and disability and a postdoctoral fellow here at ASU's College of Health Solutions. Dr. Lucy received her PhD from the University of Wisconsin at Madison in the history of science, medicine, and technology. She's currently working on a book that examines the history of autism and Down syndrome in the mid to late 20th century United States. And Emer and I are together writing a book called A Way of Being Human, which presents the history of autism and will be published 2 years, let's say, by Columbia University Press. Finally, we'll be joined by Mac McCullough, who is an associate professor here at ASU's College of Health Solutions and also serves as a public health economist for the Maricopa County Department of Public Health. Mac's research centers around the public health system, including financing and impacts of public health activities on population health. During the pandemic, Dr. McCullough has provided regular briefings for public health leaders and has researched the impacts of mitigation policies here in Arizona. And Mac was also recognized in the inaugural list of 40 under 40 in public health by the De Beaumont Foundation. We are so fortunate to have these health leaders here with us today. And let's go ahead and get started. So Dr. Dupay, you want to get us rolling here?
Okay, can everyone see my screen? All right. So I want to start by looking at a family that's trying to cross the Atlantic in the early 19th century. So in 1808, as the Campbell family prepared to leave Ireland en route to Pennsylvania, an unwelcome visitor delayed their plans. Alexander Campbell's biographer, Robert Richardson, tells the story this way. That dreaded disease, the smallpox, happened just at this time to visit Rich Hill. Alexander, with his accustomed promptitude, at once suggested to his mother the propriety of having inoculation performed upon all the members of the household who had not yet had the disease. This was the method of protection then generally employed, as vaccination had not yet come much into use. It happened, however, that before the necessary preparations could be made, some of the younger children were found to have caught the infection. Fortunately, most of the cases assumed a mild form, Jane being the only one who had it severely. She was then in her 8th year, a beautiful child, extremely fair and blooming with light flaxen hair, but her beauty was considerably marred and her face deeply marked by the disease. As soon as all were convalescent, preparations for departure were resumed. In the time and place that I study, the United States and the Atlantic world in the early 19th century, smallpox was a frequent problem. And I use this story both because it's a story I'm familiar with. I study the relationship between the rise of a market society and selling wellness in the 19th century, something Alexander Campbell did quite well, and because it reveals how commonplace this deadly disease was. In this case, it delayed the Campbell's trip, it disfigured his little sister to some extent, and the story only accounts for a paragraph or two in his 2-volume biography. But for so many millions of others, the result was death. Generally, smallpox killed 10 to 30% of those it infected. In severe cases where the pustules were so prevalent that they fused together, named confluent smallpox, it killed around 60% of those it infected. And in the worst cases, hemorrhagic smallpox, a form that caused severe bleeding, it killed over 90%. In the centuries after the Columbian Exchange, smallpox killed millions of indigenous Americans, and smallpox epidemics were common in North America from the 16th century up through the 19th. It isn't the subject of this talk, but smallpox, like disease generally, affected people differently. So class, race, ethnicity, for example, played a role in the experience of Americans and disease. However, regardless of status, in the early republic, the principal threats to health and safety were epidemic diseases. And it was clear then that isolation and quarantine were insufficient and in many cases, near impossible measures. There is still no treatment for smallpox, but many of us, perhaps most of us, have never seen it because it was eliminated from North America in 1952. And within a few decades, a global eradication program successfully eliminated naturally occurring smallpox infections. The history of smallpox, perhaps more so than anything else, reveals the dramatic success of public health mandates. But there are several others. In fact, the data on morbidity for vaccine-preventable diseases is profound. As you're seeing on your screen, in 2004, Kevin Malone and Alan Hinman analyzed the annual morbidity for 10 diseases, taking the 3-year average before the vaccine in 2004 as data points. Starting with the smallpox, the percentage of decrease was 100%, diphtheria 100%, measles 99%, pertussis 87.13 on the low end, and so on and so forth. As Malone and Hinman have argued, and as this data shows, vaccine mandates have been remarkably effective. Public school vaccines have been a substantive contributor to what this volume argues is public health's most dramatic accomplishment. The extension of lifespan from 45 years at the turn of the century to nearly 80 years today. An extension accounted for by looking at a variety of things, but clearly vaccines and vaccine mandates need to be taken into account. Interestingly, the dramatic success of public health in the 19th century, and even more so perhaps in the 20th, has often led to complacency, to mistrust, and to what Garrett Hardin has called the tragedy of the commons, an event that occurs as more and more individuals choose what is in their own individual interest, causing the benefit conferred by a common to fail. So in the case of vaccine-preventable diseases, this occurs as more and more people choose not to vaccinate. So then the herd immunity that exists because of vaccination disappears. As John Duffy has explained in his work on vaccination in schools, in the 19th century United States, as memories of the horrifying outbreaks of smallpox gradually faded, and a generation appeared which had little contact with its victims, vaccination was neglected. And the incidence of smallpox began to rise. So beginning in the 1830s, its attacks gradually intensified. And by the time of the Civil War, the disorder was once again a serious problem. The rise in cases coincided with the growth of public schools. And so in 1855, Massachusetts was the first state to pass a law requiring vaccinations for school children. Despite increased exceptions to these laws, all 50 states have since imposed vaccination laws of some kind. And public health laws throughout the 20th and 21st century have been upheld by courts, even when they force individuals to sacrifice liberty and property. Zook v. King in 1922 demonstrated that local government was within its constitutional powers when it mandated vaccination in public schools, and that excluding unvaccinated children did not violate the state's obligation to equal protection. The decision referred to Jacobson v. Massachusetts, a case from 1905, which demonstrated that a statewide compulsory mandate was also deemed constitutional. Regardless of the constitutionality of vaccine mandates, as the resurgence of smallpox showed in the 19th century, when a society forgets the danger of the disease, the remarkable success of public health measures are often compromised. In the middle of the 20th century, from the 1930s to the 1970s, federal and state investment in public health services grew. And as historian Alan Brandt argued in 1991, as patterns of disease changed from the infectious communicable diseases of the early 20th century to the systemic chronic diseases so prevalent today, perception about disease and about medicine changed. So on the one hand, scholars began to ask new and important questions about medicine, about medicine's effectiveness. But there was also a growing dissatisfaction and an associated mistrust of medicine among portions of the American population. Many among the generations of Americans who grew up without polio, without smallpox, without those rampant infectious diseases so prevalent in the American past, but who witnessed and experienced the chronic diseases that medicine still has not eradicated, developed a skepticism of American medicine, especially medicine and big business. In the case of vaccines, anecdotes about side effects and ulterior motives became commonplace and compelling, while the profound success of these public health pillars was marginalized. For us, smallpox is a historical curiosity instead of a terrible reality. But this history reveals that vaccination status is not static. Measles was declared eliminated in the United States in the year 2000, but in 2019, there were 1,282 cases, the highest number of this preventable disease in a quarter century, mostly among the unvaccinated. This history is, of course, complex. There are good historical reasons to be suspicious of governmental and/or corporate actions that claim to be in the interest of public health. Jacobson v. Massachusetts, for example, has also been applied in cases that many today would agree cause substantive harm. My interest in public health is related to my interest in the history of capitalism and the claims that individuals, businesses, and government made on what it means to be well, what it means to be diseased, and what to do about it. So it doesn't surprise me that throughout the current pandemic, the rhetoric of getting the economy going has been a common refrain from people who have opposed public health mandates, from people who have supported them, as well as from the people imposing them. This history reveals that there are tensions that exist between liberty and order in human society, tensions that must have been present in the earliest public health decisions. I think of the lepers in the book of Leviticus, quarantining ships and their cargo as they cross the ocean, and finally, the challenges of mandating an end to infectious disease. In each of these cases, to varying degrees, influential figures and public health officials were tasked with the challenging, complex, and sometimes dangerous job of selling and even imposing wellness. Some, like George Washington in the Revolutionary War, simply ordered it be done, potentially saving the Patriot cause in 1777. Others experienced the wrath of those opposed to public health policies. So prominent Boston clergyman Cotton Mather, for instance, who'd lost 3 children and his wife to measles in 1713, had a makeshift grenade thrown through his window because he was a vocal supporter of variolation during the Boston smallpox epidemic of 1721. 2 recent events, among so many others in the last 2 years, remind me that this history is in conversation with the present. In the first, the majority opinion of the Supreme Court ruling last week in National Federation of Independent Business v. Department of Labor OSHA, where justices explained that the states and Congress have the power to regulate public health and not OSHA, striking down the Biden administration's mandate that companies with over 100 employees must either have employees get vaccinated or test and mask. Whatever a person's opinion on the finding of the court, the rejection of this mandate is not a rejection of public health mandates generally. Rather, it delineates who does and who does not have legal standing to mandate public health. A long-standing legal precedent built on the idea that individuals in society have little power to protect themselves against epidemic disease, and therefore must depend on collective action and government to protect their health. And the second event, current calls from public health officials to find new ways to combat public indifference, as well as outright disregard to the dangers of the Omicron variant, both the individual dangers, especially for the unvaccinated and for those with risk factors, but also the dangers posed by the pressure that Omicron's infection rate puts on hospitals and businesses. Selling health has long been a partner to policy. Public health is not created nor implemented in a vacuum. It exists within a particular social system, and officials hope to change behavior through convincing in partner with the more coercive arm of governance. Again, these dynamics are not new. The persistence of both are a telling indication of how progress is episodic and ephemeral, lasting only as long as the lessons of the past are able to hold our attention and our commitments. Thank you.
Thank you, Dr. Dupay, for that fascinating talk. I'm going to pass the mic over to Dr. Lucy.
Thank you. So I'm going to speak a bit about the ethics of public health mandates. So I'm going to begin just by kind of going back to a little bit of what Dr. Dupay mentioned as far as the constitutional basis for public health mandates in Jacobson v. Massachusetts and Zuck v. King, then look at what the principles of public health mandates are, examine a few historical examples of public health mandates, and come back to the question of whether or not mandates are justified in 2022. So I'm not going to really address vaccinating because James did such a great job of that already. But I do want to recall the decision in Jacobson v. Massachusetts in 1905, which held that the liberty secured by the Constitution of the United States to every person within its jurisdiction does not import an absolute right in each person to be at all times and in all circumstances wholly freed from restraint. There are manifold restraints to which every person is necessarily subject for the common good. And for this, I want to be sure to highlight the way that this exposes the central tension of public health, which is what restrictions on individual liberty are permitted in the name of the common good. So Zucht v. King further reiterates the state's power to police the public on the grounds of public health. And both of these were cases that were looking at the state power to mandate public health actions. So looking at public health ethics, there's a number of principles to weigh in determining what an ethical public health action would be. So looking at non-maleficence, not causing harm, beneficence, or causing good, health maximization, efficiency, respect for autonomy, justice, equity, and proportionality, or that a public health response needs to be proportional both to the good that can be produced and the harm that a particular action will have. And so weighing these different factors is necessary in determining what an appropriate and acceptable public health response to a particular threat is. So I'm going to give a few examples of public health mandates that focus on individual behaviors. So first is the example of spitting. And anti-spitting ordinances were enacted starting in the 1890s. And these were intended to prevent the spread initially of tuberculosis following the discovery of the bacteria that causes tuberculosis and the widespread adoption of germ theory as the understanding of what causes disease. So anti-spitting laws intended to prevent the spread of TB, which was the deadliest disease of the late 19th century. And so in the 1890s and early 19th century, this early 20th century, this was the intention of these laws. With the advent of the 1918-1919 Spanish flu, public spitting laws then took on another meaning as they were intended to further prevent the spread of influenza as well as tuberculosis. So, and I do want to say spitting on the street is actually still illegal in Goodyear, Arizona. So some of these laws are still on the books. So another example of a behavior-based mandate are seatbelt laws. And every state except for New Hampshire has a law requiring the use of seatbelts in the front seat of a car. But rear seatbelt use laws vary state by state. In Arizona, rear seatbelts are only required through age 15. And we can see how state by state, the different types of public health laws are enacted. And another example of the variation in seatbelt laws comes in with primary versus secondary enforcement. And this exposes one of the tensions of expanding that police power in public health mandates. So primary enforcement means that the police can pull a car over on suspicion of not using seatbelts. And that can be the reason for pulling someone over. Secondary enforcement means that a seatbelt citation can only come following a different precipitating event. So you can add on a seatbelt infraction to a speeding ticket. And the reason behind primary versus secondary has to weigh whether or not this has greater benefits to the public versus the risks that come with expanding police powers. So this gives police greater scope for surveillance. It gives police reasons for greater potentially discriminatory actions, violating equity and justice in ways that can be highly problematic. On the other hand, it also does seem to be, based on the evidence, that primary enforcement of seatbelt laws results in greater seatbelt usage. So weighing whether or not having increased seatbelt usage is a reason to have greater police presence is something that public health ethics has to take into consideration. So another example of a behavior-based mandate would be smoking bans. And smoking bans, I think, are something that just over the course of my lifetime have become completely normalized, but were actually highly controversial when they were first introduced. California became the first state with a workplace smoking ban in 1995 and was kind of like the butt of a lot of jokes as America's non-smoking section. But since then, smoking bans have become commonplace across the country. Arizona adopted a wide-ranging smoking ban in 2007, becoming the 10th state to do so. And these days, smoking bans are common. We can see in smoking bans the way a variation in how you justify a mandate that affects the kinds of considerations that go into it. So the typical reasoning behind a smoking ban is to benefit the health of innocent bystanders. So people who aren't the ones smoking, but who are exposed to secondhand smoke. And this weighs differently than if the intention of a smoking ban is to try to prevent smokers themselves from having easy access to smoking, to make smoking more difficult, with the public health intention going in that direction. So the way that that these laws are intended will have different kinds of different effects on how we justify whether or not they're ethical. So this brings up, what should we do in 2022 amid the COVID pandemic? So in 2007, the World Health Organization put out a white paper looking at how the world should respond to a potential global influenza pandemic. And so they wrote that measures that limit individual rights and civil liberties must be necessary, reasonable, proportional, equitable, non-discriminatory, and in full compliance with national and international laws. So here we can see those same public health principles being weighed again by the WHO in contemplating what appropriate response is to a global influenza pandemic. So something similar to the current COVID-19 pandemic would be. And the Supreme Court's recent decisions, which Dr. Dupay mentioned, may have changed the legal basis on which mandates can be enacted, whether or not a federal mandate now is constitutional, or we have to look exclusively at state and local mandates. But I think in considering the ways that COVID has and continues to affect the public health, so looking at rapidly rising COVID hospitalizations and continuing high rates of COVID reported deaths, I would argue that public health mandates involving vaccination and masks are justified. All right, thank you.
Thank you, Dr. Lucy. And let's move on to Dr. McCullough.
Thank you very much. Let me get my presentation up here. All right, so thanks very much for joining today, everyone. I'm excited to be here to share some work that I did along with some colleagues here at ASU and at the Maricopa County Department of Health and the Pima County Department of Health. Just a disclaimer, as I'm sure many of us who have worked with governmental agencies can appreciate, today I'm speaking only on my own behalf, not necessarily on behalf of Maricopa or Pima counties. So with that, I want to basically jump right into the deep end of things here, and I really appreciate the two previous presenters to give us a lot of historical context. And really, I'm going to pick up right where Dr. Lucy and left off, which is how do mandates work in 2022 with widespread community transmission of COVID. So the CDC recommends universal indoor masking in schools. That is regardless of vaccination status, with the goal of reducing COVID. And as we experienced here in Arizona at the beginning of this academic year, schools took various approaches to implementing mask policies at the beginning of this year. Part of that was due to some legislative unclarity, lack of legislative clarity, whether mask policies were even allowable. And then, of course, there's varying perspectives at the school level on whether mask policies are desirable. So here's the context we had. In the beginning of the school year, this academic school year, schools resumed in July and August during a period that the CDC defines as high community transmission of predominantly the Delta variant. What happened was COVID outbreaks began shortly thereafter, right? So our goal as basically, public health practitioners, epidemiologists, was to evaluate the association between whether there was a mask policy in place at a school and the outbreaks that occurred in those settings. So this is an extremely applied project here. So this is basically just a report, right, on what actually happened in the community given the circumstances that arose here. So what did we do? We looked at the odds of a outbreak according to whether a school had a mask policy or not, and specifically whether students and teachers and staff and visitors to the school were required to wear a mask while they were inside and when social distancing wasn't possible, or whether they did not have one of those policies in place. So we adjusted for some characteristics of each school, the size of the school, whether it's they're teaching elementary or junior high or high school grades. Maricopa versus Pima County Title I status is sort of a measure of the socioeconomic status of the students served at that school. Or at least it's a proxy for that, a rough estimate of it. And then we also wanted to control for COVID transmission in the community surrounding the school. So a lot of school level COVID cases are driven by the community transmission. So a student gets COVID somewhere else, not at school, and then is a student at a school, and we sort of pick it up there. I'm going to talk a little bit more about that on the next slide here. But so what did we have? We had almost 1,000 public non-charter schools in these two Arizona counties. Maricopa is roughly the Phoenix metro area. Pima is roughly the Tucson metro area. There's a huge number of people included in both of those counties. We looked at outbreaks for the initial month and a half of the school year. We just looked on publicly available COVID-19 mitigation plans that schools are required to post. We abstracted from that whether or not the school had a mask policy in place that required mask use in the school. We have access to outbreak data from at the two county health departments, Pima and Maricopa. And then we obtained school level data on enrollment and grades and Title I status and those types of things from the Arizona Department of Education. So I mentioned we're looking at in-school transmission of COVID. This is really important to keep in mind, and I want to just stop here for a second, because what we did not want to do was measure whether there were a lot of individuals, students and staff and teachers, who happened to get COVID at the grocery store or wherever out in the community and bring it into school. What we wanted to look at was whether there was transmission inside the school environment. It's really hard to know where someone got COVID, especially given how widespread it is. But with a lot of behind the scenes work, with a lot of case investigation, a lot of contact tracing, you can come up with an approximation of where that transmission took place. Specifically, knowing what we know about incubation period, interviewing individuals, asking who their close contacts were, and tracing the spread of disease among those close contacts. You can arrive at some approximation of where we think that disease transmission may have occurred. So CSTE is the main it's the Council of State and Territorial Epidemiologists. They have this definition of a school outbreak. This is the definition we used. And we know the factors here just because of all the case investigation work that takes place both at the Pima and Maricopa County Departments of Public Health and through the ASU contact tracing team that's led by Professor Megan Jen. So we had data again on nearly 1,000 schools, 999 schools that we included in our analyses here. Just as sort of a baseline, about half, 48%, did not have a mask requirement in place. There were no requirements that students, staff, and faculty, teachers had to wear masks. They were still obviously allowed to wear masks. There's nothing preventing folks from wearing a mask, but they were not required to. 210, or about 21% of schools had what we called an early mask requirement, meaning a mask requirement that was in effect at the beginning of the school year. 309 had what we called a late mask requirement, a mask requirement that was put in place after the school year started. We also found 191 outbreaks. 16 of those were in schools with early mask requirements. That constituted about 8% of all outbreaks. 62 were in late, and 113 were in outbreaks in schools with no mask requirements. So one thing to pause on here, though, is so we can see, 8% of schools with an early mask outbreak, early mask requirement had an outbreak, compared to 24% of schools with no mask requirement that had an outbreak. 20% of schools with a late mask requirement had an outbreak, but actually a lot of those schools had an outbreak and then put a mask requirement in place. So we decided it was actually a little bit confusing to even lump all these schools in, because it would look like the mask requirement was associated with the outbreak, but actually the outbreak led to the mask requirement. So we actually did not include those schools in our analysis of the association between mask requirements and COVID outbreaks. Once we looked at all the data, we adjusted for everything that I mentioned on a previous slide. Schools without mask requirements were found to be 3.5 times more likely to have a COVID outbreak compared to schools that started the year with mask requirements. So I do want to talk through some limitations, right? These are early data from just 2 Arizona counties. So this is during the Delta transmission. Omicron may vary. We evaluated masking policies, meaning just the putting in place of a school level mask policy, not going individual by individual and looking at whether they're wearing a mask or not. Right. So there's some, you could think of this as an ecological study, or really just looking at the mask policy itself, not the masking behavior. We also did not have data on vaccination status of individuals at schools or other mitigation measures in place. That's a fairly major limitation. I wish we could do something about it. But as many of us who live in Arizona know, Arizona does not have vaccination mandates in many places, so it's not possible to get those data. And we may have to live without those data. There are more things, obviously, that we would love to look at in terms of mitigation measures. But I just did want to, I think I'll finish on this slide here. So we looked at school outbreaks for a couple of reasons. One, I do want to reiterate here, this is in-school transmission, not community acquired. We did this because conceptually, school outbreaks really matter to the parents and to the individuals, the teachers who have been quarantined at home after being a close contact of an outbreak. We hear you. That's why we looked at this. We care about it. There's also really important statistical reasons to do this, including basically lack of having the denominators to actually calculate like a case count at each school or something like that. I think one thing that we'll have to really be careful with and think really, really, really hard about is this very last bullet on the slide here is, this is not like a randomized controlled trial. This is not perfect data that we get at exactly the question to answer whatever we need to answer. So how do we make decisions in the face of uncertainty, right? School is going to happen tomorrow and next week and next month. What do we do in the meantime if we don't know exactly how effective something is? Do we err on the side of caution, or do we err on the side of not imposing a mandate on someone? That is a question that is partially addressed through some of the things that we talked about earlier, and partially is more sort of a societal values perspective too. So anyways, I appreciate the chance to share this findings today and look forward to discussing and answering some questions here.
Great, thank you, Dr. McCullough. And we've got a bunch of questions already in the Q&A box, and I'm just gonna read a few of them to get us going. And James, I'm gonna start with you with a smallpox related question, and anybody else can jump in. And the question from one of our faculty, Swapna Reddy, is, do you believe, actually it's from one of Swapna Reddy's students, Emily, do you believe that if COVID killed as many people as smallpox, would the government have enforced CDC guidelines to wear masks and become vaccinated? Tough question.
Yeah, that is a tough question. So I don't know. It's such a different comparison, right? Smallpox, as a historian, I'm thinking about it in centuries, right? Whereas COVID, we're thinking about it in terms of 24 months, right? So that's a challenging question that I don't think I have a good answer for, but I'll answer it within my field, right? So as a historian of capitalism, I would say a lot of it depends on the ability of business to continue to function. And I think, unfortunately, well, maybe not unfortunately, I don't really know how to answer that, except to say that I think it's a difficult question, and no, I think the answer is no. Yeah, I think the answer is no. I think there have been plenty of deaths to sort of rule out death being the deciding factor in whether or not a mandate would be imposed. So yeah, I'll shoot from the hip and say my answer is
Great.
no.
Mac or Emer, do you want to add to that, or should we move on to, we've got a lot of questions, up to you guys. Anything to add?
Actually, the only thing to add would just be one of the slides I really enjoyed from Dr. Lucy's presentation was just the principles of public health decision-making and proportionality and things. So I don't want to steal your thunder, Dr. Lucy, but I just wanted to call attention to that really important slide you had up.
Great.
Yeah, I would say, I think one thing that is hard to compare contemporary vaccines with the smallpox vaccine is when we look at smallpox vaccination in the 19th century, the visceral experience of getting vaccinated is very different. So you are looking not at, a hypodermic needle injecting into your arm, but actually having to take smallpox, or cowpox material from a body and preserve it in some way. You might be looking at a child with cowpox in front of you and having material taken from one of their pustules and put into your arm, or directly from a cow. And so the kind of risks that people experienced in why they objected to the smallpox vaccine are pretty different. And it is hard to compare some of the reasons why people rejected or were skeptical or fearful of the smallpox vaccine to the kind of our expectations of vaccines in 2022.
Great, thanks. I'm going to jump around and try to get to all the questions. We've still got about 15 minutes or so. But Mac, this question is for you from one of our faculty, David Sklar. What kinds of reactions did you get from media and the community about your study? And how did you respond, and anything you would do differently looking back?
That's a really good question. So I'll start with the last one. What would I do differently? I'd love to be able to put out, so one of the really tricky things in this during COVID has been the speed at which the pandemic unfolds and the speed at which science unfolds aren't always aligned. And one of the things that's really hard to do is to keep the two sequenced and synchronized. And so what I'd love to be able to do is put out more of a, why are we doing this? And what's the end goal in, why should we care about this finding today and tomorrow? And then, so basically put out some sort of a little bit more of a living, breathing thing. So, but anyways, the reaction in general, there's there are a fair number of folks who found this very powerful and compelling. This is the beauty of this study, is it happened. It's not like I went into the laboratory and had this brilliant idea for this study that we should do. This actually happened. We were reporting on patterns of disease that emerged in the community at a really, sort of critical juncture during the pandemic, right? The start of a new school year during Delta. I wish that wasn't the case. I wish there weren't these, massive outbreaks of COVID. But I think it is really important to be honest brokers of what is taking place. What I would love to be able to do differently is really stay one step ahead of things again. So anyways, there are folks who really value this information and decision making, right? Because again, school is open, right? Given that school is open and there's a pandemic ongoing, what should we do in terms of requiring masks or not?
Great. And Mac, one more question for you, and then we'll move around. And it's a question from David McCarthy, who asks, are you factoring in the impact to pediatric mental health and other long-term effects from mask wearing versus school closures and mask mandates?
So the shortest answer is yes, we're factoring it in terms of our thinking. One of the main reasons that we're interested in this topic, period, is the really profound impacts that not being in school can have on individuals and on populations. We've seen really, really powerful findings about the societal level impacts of what school closures and virtual learning environments can do, especially to K through 12 age populations. So I think viewed in conjunction, this study, right? How can we safely reopen schools? Viewed in conjunction with some other work that's going on in terms of how we can safely reopen schools. So yes, we're thinking of it. We don't, put a variable into this regression model for how, a number, but really what we're thinking of is how can we ensure that more schools remain open more often to more students? So one way would be looking at whether mask policies have any association with outbreaks. Another would be a sort of a parallel track here of what's called test to stay. We did not talk about this. That's not the subject of this paper. That's the subject of an ongoing work, both in some counties and states and nationally. So there are a lot of basically efforts to ensure safe learning environments for children during a pandemic with high community spread of a infectious disease.
Great, thanks, Mac. Couple more questions. Just reading through some of these great questions. And this is from one of our students, Cindy. In light of expanding public mistrust of science and medicine, what are some strategies for communicating in a better way findings to the public, whether they be findings related to how the vaccine works? There's a lot of belief out there that because Omicron is infecting more people, that the vaccines aren't working, even though we know that the vaccines are preventing death and severe illness. What kind of strategies might we roll out better, either later in this pandemic, because this pandemic will certainly linger for a while longer, or as we prepare for the next one? And I open that to any of our panelists.
I'll take a stab at it. As someone who works in education, sort of a broad approach, increased funding for education. I mean, that's I think a huge part of helping people be informed is increasing access to good education. And learning how to look at this stuff. I mean, this is challenging information to digest. And so the more people have the skills to be able to digest difficult information, I think the better it is.
Anybody else want to jump in?
I wish I knew. I don't. I think this is a massive question and one that it's really hard. I think it's helpful to, I think certainly, like, I agree with James as far as like improving science literacy is always important. I would say, as a historian of medicine and science, that also having an understanding of the way that our current pandemic fits into broader historical patterns, how vaccines are produced and have been produced throughout history, that it can be, for me, it is helpful to think about the ways that what we're seeing is not isolated, but reflects broader structures and historical patterns as far as the way that pandemics are developed, which certainly I think having a sense of the history can perhaps be helpful. But I also think it's difficult to know right now how to improve trust in some of the institutions that are producing vaccines that are meant to be protecting public health, when it feels like things are very divided as far as who is willing to trust and who doesn't. So I don't have a great answer.
Yeah, and I'll jump in too on this as a ethicist and historian of public health as well, in that the resistance to vaccines is nothing new. And large-scale resistance to vaccines is nothing new. James, you had a slide up, which was a parody of the response to the smallpox vaccine, which is that people thought that it was an image of people growing like different animals out of their bodies because they were being injected with a substance that was believed to have, or what actually in the case of inoculation came from cows. So there's something that sets vaccines apart from medical, other types of medical treatments in our society historically, that I think we need to be paying closer attention to in terms of vaccine education, and in terms of, helping the public understand the nature of vaccines, how they're developed, where they come from, why some vaccines give you immunity for most of your life, and why other vaccines, in the case of COVID, need additional doses more often. So I think that would be another piece of information sharing that we would really want to think about going forward, because, look, this level of pandemic is hopefully a once in a century pandemic with a vaccine solution, as well as other types of solutions, but there will certainly be other types of infectious diseases that will continue to emerge that will have vaccine-based solutions that we are going to want the public to trust and not distrust, and that we're going to want the types of information sharing that promote trust, not simply somebody's instinct or feelings on Facebook or other social media formats, but actually scientific studies that get shared in a way that help the public understand and aren't intimidating to non-clinicians and non-scientists. So a couple of more questions. Just looking to see what's in here. So this is a tough question I'll throw out that relates to this last point. It's from one of our students again. Are politics, why are politics so, embedded in this mandates question? And how do we can we tease the politics out of mandates, or, is this just the nature of this issue?
So I can take a stab at this. I think it's hard to imagine politics being entirely separated from mandates. And I think that's because of the things I was addressing in the question inherent to public health being weighing individual rights versus collective responsibilities and collective benefits. And so there's always going to be a tension there, and not everyone shares an agreement on what that balance should be as far as where your individual right to a certain behavior or so on meets the risk that it poses to others. And this is a kind of constantly shifting place, and one that I think it intersects with a lot of ongoing political questions, and ones that are not necessarily partisan, but often do result in partisan battles. And so I think it's hard to imagine that mandates can be apolitical. That doesn't mean that I think they have to be partisan. I don't think we need to have a system like we currently do, where it seems like it is solely like Democrats versus Republicans on questions of public health. But I think thinking about politics as far as like what are our values, what kind of rights do we believe in and responsibilities do we believe in, that is political. And I think that's inherent to questions of mandates.
James or Mac, you want to jump in with anything to add to that?
Yeah, I think it's one way that we can attempt to sort of tease apart the mandate and the vaccine question from the COVID question is just to look at trends in overall vaccination rates just prior to COVID. And here in Arizona, we had a declining trend, but two important parts. It was, as Dr. Lucy said, it's not purely Democrat versus purely Republican. We were seeing sort of pockets of loss of vaccination rates in a, let's call it a bipartisan way, nonpartisan way. But the glass half full is just taking a step back, right? Presidential elections and most, contested elections are like fairly close to 50-50. Herd immunity for a vaccination is often like 90 to 95%, and we're losing that. But we're still at like 90%. There are not many issues in America that 90% of people agree on. And just prior to COVID, 80 or 90% of people were vaccinating their children to go to school, right? So that's a glass half empty, because that's not high enough for what we need for herd immunity. But it's a glass half full that like there's something there that's not purely Democrat Republican talking point. So like I don't exactly know what that is. I'm not the clinician side of it, but and I'm not the political expert on it, but like there's something there that we can view it glass half full or glass half empty, depending on what side of the bed we wake up on, I guess.
Yeah, I mean, I think your point, particularly that has, over the last few decades, vaccine resistance isn't just a right or left or Democrat or Republican issue. It is bipartisan. There's an old joke on the Daily Show that where do you find the most vaccine resistors? It's aisle 7 at Whole Foods, because of sort of the belief over the last few decades, particularly on the, let's say, left side of the political spectrum, that vaccines were causing autism, which of course is not true. But that was an idea that had and has continued to gain a lot of followers. I guess what I think both of us are saying, or all of us are saying, is that we should have seen this coming. And this isn't just about this political moment. There's something broader about vaccines that have been stimulating this kind of resistance. Okay, a few more, probably have time for one or two more questions. There are some medically related questions up here. Since there are no physicians on the panel, I'm gonna skip those questions, and I would encourage you to talk to your own physicians if you have questions about the efficacy of the vaccine in different populations, although the data does show very clearly that both the Pfizer and Moderna vaccines and the Johnson & Johnson vaccine with the booster are very effective at preventing severe illness and death in those who have been vaccinated and certainly boosted, as opposed to those who are unvaccinated. And that also includes children. And even though children are at much lower risk of severe COVID and dying from COVID, there are thousands of children in this country who have died from COVID. I think the number is approaching 2,000, but I will double check that and come back with a definitive answer after I ask this, what I guess will be the last question. And it comes from one of our students, Dan, who, getting back to this misinformation question, how do we regulate misinformation? What do we do, especially in the context of mandates, whether they be COVID-related mandates or mandates in general? We live in a social media ecosystem that certainly, 2 or 3 decades ago, we couldn't have really, well, certainly futurists and science fiction writers did dream up what this could turn into, and here we are. But what do we do to push back against this? And I asked 3 health experts and historians what they think. So what do we do? Anybody?
I mean, that's almost more challenging than the other questions.
No.
And at the same time, it's not new, right? I mean, you think of the penny press in New York, right? The Sun. The Sun made its name by printing scandalous things that weren't necessarily news, right? So this idea that misinformation is a new problem in this country certainly isn't accurate, right? It's an old problem, but how do you regulate it is an entirely different question that is problematic in a country that values the freedom of speech and freedom of the press. And what it means to be press and what it means to have free speech, of course, can be contested, but I certainly don't have a good answer for that.
Anyone else? I think so. I also don't know that I have a great answer. I do think it's easy to dismiss or kind of like dismiss people who believe in conspiracy theories or who are skeptical about vaccines or other kind of scientific endeavors. I think it's easy to dismiss that as just a case of ignorance, or, that especially and all of us on this panel are academics, that it can come from kind of an ivory tower type perspective or an elite perspective. And I would say, I think it's worth not doing that and to recognize why it is compelling to believe in misinformation, what anxieties are expressed and are getting a response from that misinformation that maybe aren't being addressed by what people are seeing from, the CDC or so on. So I think it's not necessarily, I don't know exactly how to combat misinformation, but I think we need to think about the way that we are spreading information about vaccines, information about COVID in a way that doesn't assume that people who are paying attention to different types of information are doing so just because they are stupid, but to recognize that there are valid anxieties that are being expressed and to try and address those things and look at more empathetic ways, I guess, of approaching those issues.
Well, thank you, Emer, and thank you, our panelists. And just to chime in with a quick statistic about kids and COVID, there have been 3.5 million COVID deaths worldwide and approximately 12,300 deaths among those under 20 years of age. And you can see that statistic yourself at data.unicef.org and just type in child deaths and you'll find that statistic. So I want to thank our three amazing panelists and our wonderful audience with some great questions and our great discussion. Please follow the College of Health Solutions on social media so you can learn about other opportunities like this one. Our next Health Talks webinar is called What's the Truth? Understanding Statistics and Evidence-Based Medicine. Will be on Thursday, February 17th, also at noon Arizona time. And registration will open soon and will be available at asuhealthtalks.com. And thank you again. Thanks for this very rich discussion, Mac, James, and Emer. And everybody have a great day and please be safe.